Okay, you can start now. Dr. Aprajita, please keep the
Yes. Yes.
Good morning.
Good morning.
This is Dr. Muzna. So Zara, you must be knowing me.
Yes, doctor, we daily do the rounds.
Yes, Zara. Thank you for coming over here and to discuss about a certain topic that you're interested in. And as far as I know, you're interested in intussusception, correct?
Yes, doctor. Yes, yesterday we saw this child, Mary.
Yes.
She was diagnosed with intussusception. First time I am seeing this case. So I
Okay.
want to know about it. That's why I arranged a meeting.
It's really good to have enthusiastic students like you, coming to learn things. Besides you, is there any other colleague of yours who's interested in this discussion?
No, doctor, everyone is busy.
Okay, so we'll go ahead, I feel. So Zara, like yesterday you've seen Mary, okay, having this excessive crying, vomiting. So now just tell me did you read about intussusception, or what did you learn from the case yesterday? Or what concerns you have?
No, actually I was thinking the baby was crying and vomiting. So and dehydrated. So I thought IV fluids was enough. I was thinking it's just simple gastroenteritis. But
Okay.
our consultant who was seeing the child he ordered for ultrasound. I was
Yes.
surprised why he is doing ultrasound. Then the report came as the child has intussusception. Then I tried to read about it, but still I am not convinced I did not understand fully. That's why I want to ask you, doctor.
Well, generally we do not do ultrasound, right? And the children who come with acute gastroenteritis, except for these few indications, like if the child, especially in this age group, Zara, where intussusception is common. Could you help me with the age group? Which age group is it common?
Yeah, I know that once the child starts weaning, they will have this problem. This is what I know.
Yeah. Once from 6 months to approximately 2 to 3 years, this intussusception is a common age where this gastroenteritis episodes can have intussusception. So do you exactly know, Zara, what is intussusception?
I just know that a part of the bowel will enter into another part.
Excellent, Zara. Excellent.
I don't know more details about it. What happens?
It's just like a telescope, like the picture that I have drawn. It's telescoping of the one bowel loop into the other bowel loop. Generally, it's the infection episodes that have occurred that trigger this kind of a response. Are you with me, Zara?
Yes, doctor. So now how do you treat this child?
Okay. We'll go to the things of treatment and then we'll just brush on the diagnosis. So what was done yesterday for Mary, Zara? Do you remember?
I remember the IV fluids were given for
very good. Very good.
And then they were telling that they want to admit her under the pediatric surgery. I'm not sure, doctor, what the pediatric surgeon will do.
Yes. Very good, Zara. Your observation is real. You're a keen observer, basically. So first of all, IV hydration. In order to correct the dehydration is very important. And thereafter, we have certain surgical options, okay, to correct this intussusception, but because it's not going to get treated on its own. So we have this enemas, we can give air enema or saline enema that is there in order to get this intussusception corrected. So do you know like how the enemas are given or how it is?
I think it is given from the rectum.
Very good.
But I don't know. I am hearing of this air enema for the first time. You just give the air in the rectum, or I don't know, doctor, what you do?
Well, the saline enema is the better choice. Okay. So, and air enema can be used. However, saline enema is the better choice, which nowadays pediatric surgery is using. In fact, we ourselves we can even take the help of our surgical colleagues to know better about this. As far as I know, that it's under ultrasonography guidance that it is done. Okay, it is that you put per rectum this enema and see for the correction through through the ultrasound.
Okay.
Are you with me, Zara?
Doctor, but do all the children will get corrected by this, or do they need surgery sometimes?
That's a very good question, Zara. Not everyone gets corrected. Okay, there are some children who do not respond. So, do you know what do we do for them?
I am not sure, doctor.
Well, then that's surgery that is to be an open surgery that needs to be done in order to get the surgical correction for this
Can
case.
they do this by laparoscopy? Do they try this by laparoscopy?
Well, Zara, I'm really not sure about this. And in fact, this is a very interesting thing that even you ignited this interest in me. We should go back to our surgical colleagues and ask them, as well as read, and we can have this discussion in the next meeting. Like, is it a laparoscopy is present, or it's only open that they do?
Okay, doctor, no problem. I also want to know about the complications.
Yeah, about of intussusception.
Yeah, what will happen, the complications actually? I am
6 minutes.
Okay. So, Zara, did you see Mary? She was, what was happening to her? Why did the consultant think of intussusception in her?
Yeah, when I asked him, he said that the excessive crying of the baby, he was not happy. And he also told that the baby is lifting the legs and crying. And there are episodes of in between without cry.
Without crying. Very good, very good,
These
very
two
nice.
things he told me. I asked him.
Very nice, Zara. So that's right. In fact, if this intussusception sometimes, if it progresses, they can get a special colored stools. Do you know those stools? How they are? The color of those stools?
I am
the complication.
not sure. Maybe red color. I am not sure.
Red currant jelly. Yeah, red currant jelly stools because of the epithelium getting eroded, right?
Okay.
And intussusception is a kind of an intestinal obstruction. Okay.
Okay.
So what will happen if there is an obstruction?
Vomiting.
Vomiting, abdominal distension. What will you find in the X-ray?
We may find some air fluid levels.
Very good. So these are the complications that will occur with intussusception. All the complications of intestinal obstruction can happen if this is not corrected. Are you with me, Zara?
Yes, doctor, I'm with you.
Zara, I'm so glad for you, that you've come over here to discuss about Mary and having this healthy discussion. And in fact, a few things which I realize even I need to go back and ask to my surgical colleagues regarding intussusception. So, any other concerns you have?
No, doctor, I feel I will go back and read and come back to you.
Yes. And in fact, I feel we should have a meeting, you should present, if you are interested, you can present this topic with the surgical colleagues also and with us also in the meeting room, like in the room, and discuss all the aspects of intussusception so that we have a clear picture the next time we get a patient. Our management is also more effective. What do you feel? How is this idea?
Yes, doctor, you're right.
And in fact, I'll even give you all the associated material for that, reading material, and we can make it more of a pictorial kind of a presentation so that it is interesting for everyone, where you can present this case of Mary also if you are interested.
Okay, doctor, I will try to do it.
Yes. And if there is any other queries that you have, you can always come back to me. We can have a discussion. I'll help you in the presentation of the slides. And in fact, this is a very good topic because this is, this intussusception coming up as a complication. You should have a high clinical suspicion when in this age group.
Okay, doctor.
So anything
9
else?
minutes.
Time.
Summarize. There was so much of time. Why you did not ask her to
summarize? I forgot to summarize.
And you were nice till first 7 minutes. Then last 2 minutes you are speaking too much. You did not ask her.
I just forgot to summarize.
Did you give her some textbooks or leaflet? Sorry, not leaflets. Trusted websites or anything?
I gave leaflets only. Yeah.
Leaflets is for the mother. Because
But
leaflets.
educational leaflets are there, Dr. Noor, I don't know.
No, usually they say, I am not sure, but as I know, usually they say avoid telling leaflets to the students. Tell them you will give the trusted
Okay.
websites and
Trusted websites. Fine,
like
fine. Understood, understood.
like guidelines, nice guide. You can say nice guidelines if you want, no problem. Or you can say some good textbooks you will give, reference of good textbooks or trusted website like this, or some information. Or you have made some notes. You can say that I have made some notes. I will give it to you like this.
Actually, Dr. Noor, you know, when we used to do, I have done reductions of intussusceptions also. We used to do saline enema, but I was shocked that nowadays, wherever I'm reading,
No,
it's
air
coming as air
enema is
enema.
first now. Air enema.
Now is air enema first. Yeah. That's what I was.
I think you have to tell the recent update, right? So you
Recent,
will tell,
that's
air
what I was. Air
and
enema.
usually it is done under the guidance of the radiologist in presence of the pediatric
Yes.
surgeon, both of them
Yes.
together.
Both of them. Yeah.
But we
And if they fail,
action. Yes.
if they fail, the surgeon should be aware. That's why he should be there with during the procedure. If they fail or if there is any perforation or any complications, immediate surgery will be undertaken.
Okay.
But nowadays they are not doing this hydrostatic reduction, only air enema, you mean?
Air enema is the
Only air enema.
but
Everywhere, NHS
interesting,
leaflets, patient info, everywhere is given air enema. And that is
air
something
enema,
which,
yeah.
in fact,
So
air enema.
why you are telling saline enema when I was telling, I told you air enema, maybe, I am not sure.
You confused me actually, you know, Dr. Noor. You told me, okay, air enema. Then I thought probably there's something more new which has come for saline enema.
So no, and I was asking how they will give the air through the rectum like this.
How will you give the air to the rectum? You asked this question.
So if air enema fails, then they will open.
Yes.
Yeah, then they look. And what about laparoscopy? I've not read laparoscopy is done.
Even I don't know, I just asked the question.
Nah, because
maybe open surgery or
open is only done.
open is only because maybe there will be perforation or some complication, then only they will do. Otherwise, they will try with the air enema and they are successful also.
I have recently assisted for this one. There was a reduction, so you reduce with laparotomy.
Yeah, let's see. Anyone wants to give from any recent comments? So, sorry, from the recent updated guidelines?
No.
I'm just reading right now, Dr. Noor, but complications, I missed many things like infection.
Wait, I will tell you what you missed, then you add for me. In the complications, you told only there is obstruction. So you asked about the symptoms of obstruction. I said vomiting. And
abdominal distension.
radiological findings you asked, I said air fluid level. But you should also tell her that there can be perforation because what happens, here when one part of the bowel invaginates into other, or as you said, the telescoping happens, there can be obstruction, and this obstruction can cause reduced blood supply to the local bowel there, and there will be fluid leak, and so there can be ischemic changes in the bowel, which can lead to later perforation and peritonitis. Gangrene. This you missed. Gangrene, perforation, peritonitis, this you missed. So you have to encourage her, telling that whenever you see an excessive crying child with vomiting and who is falling in this age group, usually between 6 months to 2 years, and you strongly suspect intussusception, you should involve the consultant, arrange an urgent ultrasound so that this has to be reduced as soon as possible to prevent the complications. Here, prevention of complications is very important. We will tell so many things. I don't know in exam what we will say. This is the thing. Okay, but we can, there is a short I like this book, which one? This Illustrated Pediatrics. He gives very less and good information. So we can
Which one?
just go through illustrated pediatrics.
Ah.
I'm nowadays reading everything from patient info.
Yeah, patient info, but sometimes if I open it is so much that you will be like, you don't have so much of time to read. This is the problem with the
Not possible. And for part 2, we already read, so we can just revise.
Yeah. Just something small we can revise. Okay. So let's go quickly through it and then we will come with the mother's scenario. Okay, just 2 minutes. Okay. What we know, I will go first. What is the recent thing we will brush up? Okay, so all these things we know, that invagination of the ileum into cecum. Intussusception is the most common cause of intestinal obstruction in infants. This is very important. After neonatal period, although it may occur at any age, the peak age is 3 months to 2 years of age. So remember the age, usually the child will be 3 months to 2 years, or if you want to remember, even you can remember after starting of the weaning usually. Okay. The most serious complication is stretching and constriction of mesentery resulting from the venous obstruction. So this telescoping, what happens, can cause the stretching and also the constriction of the vessels in the mesentery and causing the engorgement and bleeding from the bowel mucosa, fluid loss, subsequently bowel perforation, peritonitis, and gut necrosis. These complications she forgot to tell. She told only about obstruction, but she did not tell that there can be the obstruction in the blood supply, which can lead to obstruction in blood supply, which can cause the engorgement and bleeding or fluid loss and bowel perforation, peritonitis, and gut necrosis. All these things you have to remember. Prompt diagnosis and immediate fluid resuscitation and urgent reduction of intussusception is essential to avoid complications. This you have to mention to the student, because you should rush, if whenever you suspect, you should rush for the diagnosis, because it needs immediate and urgent reduction to prevent complications, and also fluid resuscitation has to be done first. Presentation is typically with proximal severe paroxysmal severe colicky pain with pallor during the episodes. Child becomes pale, especially around the mouth, and draws up legs. There is recovery between the painful episodes, but subsequently the child may become increasingly lethargic. May refuse feeds, may vomit, may become bile stained depending upon the site of intussusception. A sausage-shaped mass is often palpable in abdomen. So passage of characteristic red currant jelly stool comprising of blood-stained mucus. This is a characteristic sign but tends to occur later in illness. Just don't wait for this sign to come, because it usually occurs later and may be first seen after rectal examination. Maybe if you do per rectal examination to the baby, your means the gloves may get stained with this red currant jelly stool. But don't wait for this. As soon as you think that he is excessively crying, severe colicky abdominal pain with drawing up of legs, and child becomes pale during the episodes of the pain, the child becomes pale and you suspect, just go for the ultrasound. Abdominal distension and shock can also be the presentation. Because of the obstruction, they may have abdominal distension. And fluid because of the obstruction to the blood vessels, they can have the local fluid loss, engorgement, and perforation, gut necrosis, perforation, and peritonitis. Usually no underlying intestinal cause for intussusception is found. Although there is some evidence that viral infection leading to enlargement of Peyer's patches may form a lead point of intussusception. So we should also know that if they ask, maybe they can ask that what is the common cause in children. You can say that there is no underlying intestinal cause for intussusception is found, although they think that whenever there is preceding viral infection, there can be enlargement of Peyer's patches, which can be a lead point for this. An identifiable lead point such as Meckel's diverticulum or polyp is more likely to be present in children over 2 years of age. For younger children, usually it is viral infection followed by enlargement of Peyer's patches. You can suspect of Meckel's diverticulum and polyp for children over 2 years of age. IV fluid resuscitation is likely to be required immediately, as there is often pooling of fluid in the gut, which may lead to hypovolemic shock. So tell her that you will give immediate fluid resuscitation. Then an X-ray of the abdomen may show distended small bowel and absence of gas in distal colon and rectum. So there can be distended small bowel due to obstruction, and since the gas will not go beyond that, there won't be any gas in the distal colon and rectum.
Like in the Hirschsprung.
Hirschsprung, yeah. Like no gas, Hirschsprung's mainly no gas in rectum.
Rectum.
Yeah, here he's telling large bowel and rectum because the site of obstruction is ileum, near the ileum and cecum.
And you know, he said like there can be bilious or non-bilious vomiting, but anything beyond duodenum is bilious vomiting.
Yeah, yeah. Sometimes the outline of intussusception itself is visualized. Abdominal ultrasound is helpful both to confirm the diagnosis and to check the response of treatment. So ultrasound will help you for the diagnosis and to the response of treatment. So what is the ultrasound? This is all very important. You should know that the target or donut sign, maybe they can ask this. The role player can ask this. What do we see in the ultrasound? So target or donut sign. Then unless there are signs of peritonitis, if there is no perforation and peritonitis, reduction of intussusception is by rectal air insufflation is usually attempted by a radiologist. This we should know. Okay. If there is no signs of perforation and peritonitis, usually they go for reduction by rectal air insufflation. That is, we say air enema by radiologist. This procedure should only be carried out once the child has been resuscitated and is under the supervision of pediatric surgeon in case the procedure is unsuccessful or bowel perforation occurs. So the radiologist will do, but in presence of pediatric surgeon. The success rate of this procedure is about 75%. The remaining 25% requires operative reduction. Recurrence of intussusception occurs in less than 5%, but more frequent after hydrostatic enema. So now you will directly tell air enema, then if failed, they will go for the procedure. It's not mentioned here about hydrostatic, and he's also telling that there is recurrence chance is more with the hydrostatic. Okay, this is the most recent one. Another, I want to ask, anyone knows, someone had written about the laparoscopy here. I don't know from where is the...
That actually is Ghosh NHS leaflet has given that.
The operation...
Patient info has not given it about this, but Ghosh has given that you can use laparoscopy.
Using keyhole laparoscopy, but occasionally the surgeon may use open surgery through a large incision in the abdomen. So that means even if this is failed, they can try laparoscopic also. But for me, if there is complications like perforation and peritonitis, I don't think they will go with laparoscopic. If complications, without that, unsuccessful, like just reduction is unsuccessful, maybe they can try laparoscopic.
Hello, I have a question. Can I ask?
Please go ahead.
So is air enema done under any anesthesia?
I don't know really.
Well, I
On
don't think.
sedation can be done maybe under conscious sedation. I'm not sure. So if such question arises when you're not sure, you can tell that we can go back and discuss with the radiologist who will be doing this to know more about it. Okay.
Okay.
What air enema requires what?
Does it require anesthesia? Yeah.
I don't know. We do here without anesthesia, but
No anesthesia. No anesthesia.
no anesthesia,
No
yeah.
conscious sedation also.
Maybe conscious sedation we can give, but I have not seen. I have seen many patients, but they are doing by intervention radiologist, but maybe some sort of little conscious sedation,
not-
but overall they are doing without anything.
Not general anesthesia, but local can be or not.
No, local. How can you, Krishna? How can we give local? Because intussusception mostly in small children, in primary. They are very irritable, but there was this one. So they tried with conscious sedation initially. If it is not redux, they go for general anesthesia for laparoscopic or whatsoever they want.
Okay. Maybe conscious sedation, we are not sure. So what we can tell is we will go back with them. This is better.
Hello, Dr. Noor. It's Roma here. Sorry, my son's name is coming on. I just realized. It's coming from Hussein Umar. That's my son's name on Zoom. But it's Roma.
Okay, welcome. How are you?
Not very well, but I'm participating. I just want to say, yes, sedation is given for air enema, and it's done by pediatric radiologist. I myself have been there. I have seen such a case and was with the child as a part of pediatric team. And then yes, the operation usually when in our hospital they do open, but it depends from hospital to hospital and surgeon to surgeon as well. So I think the candidate today has done very well by saying that I'll check with my surgical colleagues if you're not sure. But there are few procedures like these which are still controversial, that what should be done. Of course, if you suspect that it's kind of a severe intussusception and you are predicting the child is very severe, there is a highly likely chance of having gangrene or perforation, it's getting delayed and stuff, they will go straight to open. But if they suspect it's mild intussusception, then they can start with laparoscopy with a consent to
ultimately we have to tell her that all depends upon the condition of the child and the decision of the surgeon.
Yeah, and she very well said that I'll check with my surgical colleagues. So this will just save you. No need to go into the details. But about the sedation or anesthesia question, that's a very good question, because that could be a potential question from the role player. Then you tell, yes, the air enema is given under sedation. And then if, because most of the kids, they don't bear that positioning. It's not about the air enema and local. There's no such local thing for this procedure. It's just an enema. Basically the child has to be still on the radiographic table. That's why they need sedation. They need like really dozing off. I hope my point is clear.
Yeah. That's what. Yeah. So even my thing was they will give conscious sedation.
Yeah, agree.
And I think we should follow what they follow, like what we are doing. Maybe it's different.
Dr. Hussain, Umar, are you working in some UK hospital? Sorry to interrupt you.
Working.
Okay.
Yeah.
Thank you for get a lot of feedback from you then.
Yes, because we cannot, because here we can do anything. Whatever we do is not according to their protocol. We should follow their protocol, like, what they are doing there. It is the standard. We have to tell that only.
Okay.
Right.
As we all know that this was the case in the recent Jeddah exam.
Dr. Yasir, you are working there?
Dear, I am working in Riyadh in Saudi Arabia.
Okay, okay, Saudi
Before it,
Arabia.
I
Okay,
was working in Children Hospital in Lahore, and it is the, you
okay.
can say, main hub of every
Then
time of every type of patient we have encountered and we have seen.
yes, yes,
So
yes, yes.
that's
I have also worked various institute, but this is, this is something which we follow NHS. So they
yeah,
are
yeah,
very, particular about, because we don't care
That's
about
why,
much
that's why,
all this.
that's why, Dr. Krishna,
Yeah, we should follow.
often
Yes, yes,
we read, we have to just go through at least a small, at least
yes, yes, yes.
one of
Because
their.
we should not, what I mean to say, we should follow what they are doing. That is my point.
yeah, yeah.
Dr. Krishna,
Doc-
my husband is working as an intervention radiologist in NHS, Birmingham.
Yes, yes, yes.
What he told me is
Uh-huh.
that they don't prefer doing those air enemas, but I'm
Mhm.
not sure about sedation. I'll ask him today and
Yes, yes. Please
confirm in
ask.
the
Please,
group.
please.
Okay?
Yes, yes, yes. Please ask. Please ask. Those who are working in NHS, they can provide us the better guideline, like
Okay,
what they are going
Okay,
through.
I'll ask him.
Yes, yes, yes.
okay.
Please, please.
Dr.
Yes.
Faiza? Hello, Dr. Faiza, you're here?
Dr. Fatima, next case, who is doing? Dr. Faiza is doing or me?
Wait, I don't know, she's not here. Okay, you want to do with the mother? We will not give
And
start directly.
I can do any scenario you want. No problem.
Yeah, because this scenario actually in the exam had come with the mother, but we are also doing with the role play, medical student, thinking that it can come with the medical student also.
Mm-hmm.
So now we will do with the mother,
Let
which
us,
came in the exam.
let
Okay.
us wait.
At
Yeah,
8,
yeah.
we will go to the next scenario. Okay.
If she wants to do.
She is not here. I called her 2-3
Okay.
times. Faiza.
Okay. Okay, fine.
Because we
Yeah.
have only 9 minutes, then we have to go for the
Yes.
next scenario. That's why.
Yes, 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 yes.
Okay, so who will keep the time? Dr. Aparajita again? Or I will ask someone.
Okay.
Okay, just we will start, huh? Okay, start, Dr. Krishna. So wait. The mother's name here, baby's name is Mary. Mother's name here is Mrs. Cheryl. Okay. Do you want the scenario again to be repeated?
Baby name. No, I don't know the scenario.
You don't know the scenario.
No,
So
no.
Mary is 6 months old,
Mhm.
presented with excessive crying, vomiting, was dehydrated. Okay.
Mhm.
Intussusception was suspected and an ultrasound was done and diagnosis of intussusception was made. Discuss the diagnosis and management plan with her mother, Mrs. Cheryl. Cheryl, okay?
Okay, I want to explain to the mother.
Yes. About the diagnosis and management plan of Mary.
Okay. Okay, fine. And now she's stable or unstable?
Now she's stable. No, now you are just resuscitating with the fluids. Now you have to tell her how you
Okay.
will manage the child.
Okay. Miss Mary, okay?
Child is Mary, mother is Cheryl.
Cheryl.
Okay.
Okay. So, good evening, Mrs. Cheryl.
Good evening, doctor.
I'm Dr. Krishna, one of the pediatric registrar working in the hospital. Hello?
Yes, doctor.
Yeah. So is this the right time to talk with you? I want to talk regarding the condition of Mary. Will that be fine with you?
Yes, doctor. I am very much worried about her. From yesterday, my baby is not taking anything. She's vomiting. I don't know what's wrong with her. Can you please let me know?
Yeah. For the same, I'm conducting this meeting. Before starting, I would ask you, do you want anyone else to attend meeting with us?
No, doctor. I
Yeah.
am alone here. You can go ahead.
So, since Mary was unwell, since yesterday, and now we are giving him whatever the body is requiring through her blood. Okay, not with the mouth. Okay,
Okay.
because as you notice, she was having certain throwing out episodes and some problem with the tummy.
Okay, doctor, what exactly, why she's doing like this?
Yeah, this is we call in the medical terminology, we call it as I will explain to you. First, I will tell you the medical terminology we use. It is intussusception. Have you ever heard about it?
Oh, no, doctor, this is a new word for me.
Okay. See, Sharon, will that be okay if I address you with your name? Will
Yes,
that
yes,
be fine?
no problem,
Okay.
doctor.
Yeah. So we whenever we eat through the mouth, through the food pipe, it goes. It get digested in the tummy and in the larger food pipes following the tummy.
Okay,
Okay, and then it goes the waste product. It goes via the back passage. This is the normal phenomenon in everyone's body.
okay. So,
What has happened? Yeah,
yeah, yeah, yes, doctor, tell me what has happened.
what has happened is like after passing through the tummy, there are through the larger pipe, the two in the interconnection between the two pipe was disturbed. Okay,
Okay, so
like
show her in a drawing that there is a big
yeah,
pipe.
but you know, Dr. Fatima, they said in the this demo they are not allowed to, you know, you cannot show the drawing sometimes in the camera. But still, if you want, I will draw the diagram for you.
Go ahead. Okay, okay, then.
Hmm. See, this is the larger foot pipe. Sometimes what happens, they get into one another rather than maintaining the continuity.
Okay,
Like
so
in the picture, you can see.
what has happened, doctor, exactly with my child?
Yeah, this is what in has happened. The food pipe get entered into one another,
Okay.
so there is no continuity of the food.
Mm-hmm.
So you know, the food is not getting digested, is not following the path because of this locking in between the food pipes. There
Okay.
is some blood. So that is how it is going. But the good thing is you come on the right time.
Okay, doctor. So what do you do for my baby now? Uh, what are you
Yeah,
going to do?
yeah. As we already did the sonography, the jelly scan of the heart. Okay. Sorry, jelly scan of the belly, which confirm that it is the intussusception.
Okay.
Uh, now we are going to place these larger foot pipes into their positions with the help of
Okay.
pushing the airs.
So doctor, what you will do with my baby now? How you will remove this? He's just 6 months old. Maybe he may have pain and lots of problems. I'm getting worried now. So how you do this, doctor?
Yeah, we have an expert doctor who usually do these procedures, who are expertise in this. Okay.
Okay,
So
doctor, but still, for the 6 months old baby, you will give the air and you think it will get and my baby will be fine, because I am worried the way the vomiting, something wrong may happen with the baby. So can you?
yeah. See, I can see that you have a doubt regarding the procedure, right? Like
Yes, doctor, and also I am worried. My baby is not at all taking anything from the mouth. Maybe my baby may die. This is my worry.
No, regarding the, if she's not taking from the mouth, we are giving him all the necessary things via blood. You need not to worry about that.
Okay.
But if you
6
have a
minutes.
doubt, if you have a doubt regarding the procedure, I can explain it to you. Not a problem.
Okay,
Or if
doctor.
you
So
want to,
now, how will my baby be fine by this procedure?
see, most of the times, this procedure gets successful. Okay.
Okay.
But there are chances, and it is not, it is done by some experts. So most of the time it gets
Okay.
returns to the normal in sometimes, but sometimes there
Uh,
are chances of failure in any procedure. Okay.
okay, doctor. I am worried. Will this procedure will do some complications for my baby?
See, the short-term complications are there. Okay, but in long term, I can assure you that this will not cause any permanent damage to the baby.
Okay. Do they give any sleeping medicine for her?
Yeah, this will be better. It all depends. Like, I will arrange a meeting with the pediatric, the child surgeon doctor, the radiologist, and my consultant.
X-ray doctor. Okay.
Like, how they are planning to go with the procedure.
Okay.
Is that fine with you?
Yes, doctor. Okay.
Yeah. So you have any other concern?
No, doctor, I don't have. I'm worried only about how the things will work out.
Yeah. Definitely, it will go smooth. Hopefully, we'll do our best, and we are here to help you anytime.
Okay, doctor.
Yeah. So shall I summarize to you what we discussed so far?
Yes.
Yeah. Like I have, Miss Sherry, I have explained you the diagnosis, like what was happening, what was the cause of she was unwell since yesterday, and the what procedure we are going to do, the complications of the procedure, and I reassured you that I will definitely arrange a meeting with the doctors, the child doctor, child surgery doctor, the jelly scan doctor, all those who will be getting involved in the procedure, and my consultant, and they will give you a good idea as what's to be done next. You raise the concern that there will be any complications, so there will not be any long lasting complication, that I can assure you. Okay.
Okay, doctor.
Okay, thanks for coming, and you can anytime you have any query, you are most welcome. Okay. Yeah.
Okay.
Time up.
I think there was some problem in your communication. There were some
Okay.
jargons also, and you were speaking too much, and your starting was not good because,
Mhm.
for example, now this is a information giving scenario. First,
Mhm.
after introducing yourself, like I am Dr. Krishna, one of the I prefer to say more than pediatric doctor, I prefer to say children doctor.
Mhm.
Or if you're for a neonate baby doctor, like this, it's better. This is my personal preference. I am one of the children doctor in this hospital. Today I am here to speak to you about Mary. You can just have a rapport by asking her how are you, and maybe she may say I'm worried about Mary, like this. After you finish all these things and asking for the attendant, immediately come to your topic.
Mhm.
You are reluctant to say the word interception. I know. You can say the word and explain, then it will be no longer a jargon. So directly come to, today I am here to speak to you about Mary. Mary has been diagnosed with a condition called interception. Have you heard about it? Like this. Yeah, she may say, oh, this I'm hearing for the first time. What is this, doctor? I'm worried like this. Then first, when she is worried, first give her empathy and sympathy first. Then you explain. Like, oh, Mrs. What is her name? Cheryl. Oh, Miss, I can understand that you are worried and your baby is very small, but we are here to support her, to take care of her, monitor her, like this. And first you give her empathy, sympathy, then you tell her what is interception. I hope you got my point. You were to say the word interception itself, I think you took a long time thinking that I will say or not. Like, no, tell her. Today I'm here to tell you about your daughter Mary's condition. She has a
Disease
condition called
condition.
interception. So have you heard about it? No, doctor, what is it? Then you explain to her, this is what happens, and you're telling food pipe. No, food pipe is esophagus. Use the word small bowel and large bowel. Is bowel jargon?
Bowel. Bowel jargon.
Bowel is jargon. Anyone can
Yes.
tell us?
Yes. Bowel is
No,
jargon.
no,
Bowel
bowel.
is jargon.
Bowel is a.
No,
Yeah,
you
you
can
can use the gut, but bowel is also fine. They do understand. People here do understand.
we can ask as a bowel is opened or not. So I think bowel is open. Bowel is fine.
Okay, you cannot use
Yeah, it's very common.
intestine. Avoid
So
intestine.
why you say poo? You have concern regarding poo. You can say you have concern regarding bowel.
Bowel and bladder habits, we say, right?
Bladder is also jargon. Which bladder?
No,
Like
no, I am telling you. I think bowel you can use. This is my
gut.
thing.
I think gut will be better.
So you can just say there what happens in this condition is the small bowel will enter into the large bowel. This is what is we call it as telescoping, like this. Draw a diagram, keep it ready before. I don't know about the online, but for face to
Online they said no. Online in online exam they said if you draw the diagram how much we can see, you never know, so avoid in the last.
Agreed, they said that, but we can make a statement. See, I'm drawing for you, and you can see it means if at all this kind of a scenario, it will still be pardonable. Yes, they said in the online, but I feel
This
there
is
is
what
such
they
kind of a
said,
scenario
like
where drawing is essential,
just
like evidence-based
tell how
medicine.
she will understand. The way you said, I did not understand only. Really, I'm telling you, as a doctor, I did not understand. Then how the layman will understand? You're telling the food pipe will go. Food pipe, everyone, food pipe and windpipe is, food pipe is esophagus, windpipe is trachea. No one will think it as bowel. Okay, so use the word small bowel. You can use the word getting into
gut.
the large bowel, and this is causing the obstruction. So the food cannot be passed, and there is an obstruction. So your baby will have tummy enlargement, vomiting, and
The
also
other option, Dr. Noor, for
dehydrated.
this would be showing it with your hands, putting
Yeah,
your one
exactly.
hand as a and showing it going into another hand and showing that the bubble loop is going like that,
Yeah,
like a
yeah. I was
telescope.
also, yeah, I was going to say that for online, this would be a better option, to show it in the video like that.
Yeah, khalas, draw or show, do something, do some action. Just don't try to explain by the words. I don't think this can be explained by the words to the layman. Either if you are allowed, use the diagram or show with the same thing, like there is a telescoping of one bowel into the another, or just say that the small bowel is entering into the large bowel, and here there is obstruction. So your baby has vomiting and the tummy is enlarged. And also there is some fluid loss due to this obstruction. They will understand. Anyone can understand obstruction. Due to this obstruction.
Blockage can be used.
Blockage, yeah.
Yeah, blockage. Okay, blockage. Use some and tell her that there is some fluid loss. Because of that, there is also dehydration. So we are giving her with the giving her fluids through the blood.
And what about the term intestine? I mean, don't laymen understand intestines? I mean, they understand liver, kidney,
No.
intestine, isn't it?
No,
Even
intestine.
they don't?
And better to be on the safer side. I feel like this.
Yeah.
It all subjective.
Yeah,
It
blockage.
is also.
You tell her also that so we want to treat this condition as soon as possible. So when she asks some questions which you don't know about the sleeping medicine or anything, you can tell that why you use the word radiologist.
Radiologist will be involved in
Yeah.
this.
So what is the
So
alternate word for radiologist?
radiologist is, they can pediatrics, radiologist, they can understand.
I don't know. When you are not telling ultrasound, you are using jelly scan, and for the bacteria, you are using bug, and for obstetrics, you are telling obstetrician, you are telling women.
Even pediatrician, we are saying child doctor and baby
Yeah,
doctor.
child doctor.
Dr. Noor,
Doctor.
we can
I don't
sorry.
know.
X-ray doctor, right?
Huh?
I don't know. X-ray doctor.
No, we can just say
Jelly.
the specialist doctor. Just save yourself. Just the specialist doctor will do this. You will not go wrong if you're not sure, because some people do understand, some people don't. But it's a bit of a speciality which is not everyone encounter in their life. Just say a specialist doctor will do this. As
And I will arrange the meeting with him. I will arrange the meeting with him to know about the sleep medicine or what exact procedure.
The team of doctors who are going to perform the procedure, I will arrange a meeting with them.
Yeah. But for surgeon, we are using surgeon usually, right? So
yes, surgeon is everyone understand.
Yeah. I don't know. Radiologists, do they use X-ray doctor or something? I'm not sure. We can check it in some book if it's given. Or a specialist doctor who is concerned for this. Like this, I think there was something wrong in your scenario. Go back and check it, okay? There were some jargons and you took long time to tell her interception, and at last you were speaking too much and the role player was speaking less. So if stop yourself and ask her, are you understanding? And whenever she is telling you that, no, I am worried, tell her, cover her with empathy and sympathy before you give her the answer. Like, yes, Mrs. Sheril, I understand that this is your small baby and you're worried about her, and we are also working hard to take care of her. So we will do the best for her. Like this, cover her with this thing and then tell her what she wants the answer. This is how you will do the communication. If she's telling you, I am worried, and you don't respond to it and go to answer her concern or explaining about sleeping medicine or something, they will negate the marks here. They'll cut the marks here. This is my impression. Anyone wants to give the feedback, please go ahead. I think there is a leaflet from NHS Ghosh for this interception with the mother for the layman's language. So
what is Ghosh?
Great Ormond Street Hospital.
Oh.
Okay, so just go through it because now we are getting late. We'll go for our next scenario.
Okay. So next scenario, who will be the candidate?
Dr. Rahma is the candidate for the next scenario.
Yeah, I can do that.
Okay, I will keep the time.
No.
Okay.
Please, I don't want time. Thank you.